Today we want to look at what is the epidemiology and clinical characteristics of injury. Now, before we speak about injury prevention and risk management, we need to know what is this injury profiles. We're also going to look at what's the injury risk in trail that we know about. We're going to look into those that are interested in research into this field. Where are the gaps in the research field? But we're also going to take a bit of a clinical approach to it. And in the context of what we know, what can we do for these guys out there? Okay, so this is a summary of the learning objectives that we're going to look at today. This video has no sound, so don't worry about if you can't hear anything. It is just a presentation of, or maybe a bit more of an extreme example of what trail running is. So it's various off-road running terrains that you can be exposed to. There's a lot of elevation gain. It's not placing your foot in one set stride. You have to change your foot placements. You'll be challenged in multiple ways. There's also no limitation on the distances in these sports. So it can go from a 5 kilometer, like the Al Samla race, we go up to 400 kilometers. So it is such a wide variety of exposure you get in this sport. If we then look at running surfaces, for example, we talked about it now. You can go on rocky cliffs, grass, nice manicured trails, desert environments. You can get softer desert sands, harder terrains in the desert, and even snow. So later when we talk a bit about the clinical approach, we have to think about this complexity in the sport. It's very difficult to take a similar approach to road running or cross country to the sport. You have to understand context of where your runner is going to participate, and then think about how can we simulate this type of environment when they go into it. Also, we have to think about the variability in a single run that can be. This is the Western States example, where you start in snowy conditions, soft underfoot, where later you end up in extreme heat, a bit more manicured trails. But we also have to think about this variability that trail running brings in a single race, and how do we adjust our approach to that? The other thing, the issue in trail run, it's not an issue, it's a fantastic thing that you go out and you have an adventure, but you're self-sufficient or semi-self-sufficient at least, meaning you have a running pack with you. In this running pack is basic gear where you can keep yourself warm or prevent yourself from getting wet against the rain. You have your own nutrition with you, your own fluids with you. So you have to get from one aid station to the next safely with whatever you have on you. Now, the problem is if we consider there's quite a higher incidence of injury in the sport, we have to think about this problem and the consequences of getting injured in the sport. Let me first start with road running. So the Comrades Marathon in South Africa is a very popular race, and it's 90 kilometers with about 45 refreshment stations and 8 fully equipped medical aid stations. So if you do get injured in the Comrades, you can easily go sit down, and an ambulance can easily pick you up if there's a problem. You can't continue running. It's very easy to get you off the course and get you to medical support quickly. The problem in trail running, now I'm using a mountain here as a picture, but this can be a desert, it can be snowy environments, but let's look at the problem here. A typical race in South Africa has 8 checkpoints. These checkpoints is not medical aid stations. It's just checking you in to make sure, okay, you've reached this point and continue on to the next one. We know where you are. It on average has 1 to 2 fully equipped medical aid stations. So if you get injured out there on top of the mountain, and let's say it's a misty day with difficult helicopter access, it becomes firstly an issue to reach you. It will take hours to get to you. And then when we reach you, it will take hours to evacuate you. And here you have to consider a normal ankle sprain where I can't move, I can't walk any further. I have little equipment with me, I'm sweaty. So in mountain environment, I can easily get hypothermia. So this is an example we have to think about the consequences of getting injured. If I, for example, get a fracture out there, or I fall and I have a bleed that is difficult to stop, that becomes a life-threatening situation. In trail running versus in road running, it's easy to get to you. These aid stations or the checkpoints are often also mountain huts. Now, there's an example. There's basic food and equipment there. It's very difficult. Even if we get you to the closest aid station, it's not to say we can help you there, We often need to get you off the mountain or out of the desert to a medical facility. So this is what I want us to see in context, and the consequences of getting injured in the mountain is a little bit more problematic than in normal running. Now, if we say injury is a problem and we need to do something to it in the sport, if I look at the normal sequence of injury prevention, I know there's multiple additions to this model, but the basics always start with we need to know what is the epidemiology of injury, and we need to know what is the risk associated with this sport so that we can introduce prevention programs or risk management programs. So this is where we started. We started to say that let's look into the sport and let's see what is the real issue here. So a few years ago, we did this first systematic review where we reported on the incidences, the prevalences, the clinical characteristics of injury. We added illness to this, but today's talk is more for injury. We followed this review up with a living systematic review that focuses more on the risk factors for trail running. We do update this review every 6 months. So the paper here is already updated. You can follow the website to find the updated information there. But most of the talk and the risk profile, I'm going to tap into these two papers to give you an overview of what we know at this stage. So at this stage, we only have 25 papers out there that reports on injury in trail. Now, if you compare this to the hundreds and hundreds of papers in road running, we are far behind in trail. Okay, so what do we know? We have 22 studies that focuses purely cross-sectional. Now, you guys know the issue with that and not accounting for the temporality of risk in these type of study designs. We only have 3 studies that has a prospective approach with longer follow-up periods. We're sitting with the issue in study design, and we only have 3 studies out there in trail running that has longer follow-up periods, meaning at least a 6 months follow-up in the sport. Most of the studies focus on race participation. Sure, in the training race / race participation, we have 11 studies, but these studies, we are not exactly sure what they focused on. It is, for example, they'll ask them, in the past 12 months, tell us about your injury. So we're not sure if those injuries were linked to training or race participation, so we have to see that in context. For these race participation studies, mostly it is ultra-marathon distance. There's only 2 marathons and 1 sub-marathon. Obviously, one study focused on multiple races. So, and again, in clinical practice, we see the guys that get into big trouble are these shorter distance guys, where you come from road running, you're not very experienced in trail, and you enter the 21-kilometer in trail. Now, 21-kilometer in trail can easily take you up to 4 hours to complete. But these guys are not prepared for it, and so we see our bigger problems on these shorter distance runners. And in literature, we have very, very little scientific evidence to guide us here. Then the literature mostly focuses on men. And again, we need to think, what unique risk can women bring into this area of risk factors and injury in trail? But this is what we know. And the rest of the presentation, I want us to see the findings in the context of this. Okay, incidence of injury. Again, only 6 studies reported the incidence per 1,000 hours of exposure. And I'm just going to focus on the minimum and maximum values here to just give a context to it. So the minimal value here was a study that reported on minor skin injuries, and they focused on medical encounters. So it's highly unlikely that a trail runner is going to go for a normal small abrasion, is going to go to a doctor and ask for assistance for that. So again, it makes sense why the incidence was quite low. Then our max value was 65-kilometer ultra distance runners. This race went up to 4,000 plus meters, and the definition of injury was any new onset of pain or discomfort. So I don't know about you guys, but if I think very few people are not going to have pain or discomfort when they run 65 kilometers with 4,000 meters of elevation gain. Okay, and this is the issue in the studies at this stage as well. The heterogeneity in reporting and definitions used in injury, we have to just see this in context. Same with prevalence. If I focus on a minimum value, this is in pre-race medical screening. Now, we don't stop runners. We do a lot of pre-race medical screening to identify the obvious guy at risk that shouldn't be participating. But these guys are scared, obviously, that we're going to take them out of the race. So in pre-race medical screening, we see this very low injury prevalence. No one wants to tell you that they are injured. And then obviously then with the max value, these were guys that regularly participate in ultramarathons, and it was a very small sample in the study, and obviously they reported a bit of a higher prevalence. So at this stage, we have few studies guiding us in this incidence and prevalence of injury in the sport. If you focus a bit more on the injury profile and where do these guys get injured, now obviously this is running, and we expect the lower limb. That most studies report the lower limb as the anatomical area of injury. I just want to highlight that as our living systematic review is now getting more and more studies, it's more and more studies are reporting on the head and neck and the upper limb as anatomical areas of injury. We'll now look into the pathology types, and it might explain it a bit more. In the body area, the foot and toe and ankle is some of the most common areas that we see are injured. I just want to put it in context again. The foot and toe, if I go to the next slide here, the foot and toe is maybe related to blisters. So most of our studies are ultramarathons, and a few studies only focused on blisters in ultramarathons. So this might explain why we're sitting with this superficial tissue or skin and the foot and toe as being so commonly reported in studies at this stage. I just want to highlight that we need to start thinking, and we can afterwards in the clinical side of it chat a bit more about this, is that we do see acute injury or sudden onset injury a lot in the sport. I understand the issue of the definition of sudden onset. It can be a tendinopathy that just suddenly shows symptoms, but we see these joint sprains linked to ligament and capsule injuries commonly in this sport as well. If you look at the pathology type, you can see that joint sprains with tendinopathies are currently the most commonly reported in injury-related studies in this field. So can you take a similar approach to your normal cross-country and your normal road running to the sport? If you know that this joint instability episodes are so common, something that we can think about. If we go a little bit into the subcategories of it, and I did highlight the issue of sudden and gradual onset definitions, but in one prospective cohort study that we've done, there was not a statistical significant finding, so please see it in context. What we just saw, this sudden onset of injury was actually more than our gradual onset of injury. A more recent study looked into more younger runners at elite level, and they found that almost half of all their injuries are sudden onset ankle sprains. Okay, so this is really joint instability episodes is something we really have to consider in the sport, and how do we take a different approach to this compared to normal running. If we go into race distance categories, is a 100-kilometer or 100-mile distance athlete someone that focused on the Al Samla race? Do they have a similar injury profile compared to a shorter distance mountain marathon or mountain runner? This we have to consider. Science is not guiding us too much because we have very little studies in the sub-marathon category and in our marathon distance. So if you're a researcher interested in trail, this is the place where you need to dive into and help us build evidence in this field in this very vulnerable population. The two prospective cohort studies that went on a bit of a longer follow-up period, one was done in a Dutch population in Amsterdam, and one was done here in South Africa. Now, again, the problem here is that we know that these guys participate at least in half marathon distances, but not in one of these studies that they differentiate and said, okay, but these are the 100-mile athletes or guys training towards a 100-mile. These are guys training towards a 20-kilometer distance race. So we don't know. We did find injury profiles in the studies, which is fantastic, but we don't know is this linked to shorter distance guys or longer distance races. If we just talk about age and level of participation and genders, so very few studies have focused on this. This is one of the newest studies that now reports on the younger trail runner, which is fantastic, and also at elite level, which was not done before. So this is also an area where we need to dive into. And what does an elite athlete, how does their approach and their mindset to the sport differ from a normal guy that just wants to complete the race and takes it a bit safer? And here, before I highlight this, I want to highlight and emphasize that this is less common. but we do see more severe injuries in the sport. There is reports of acute fractures, concussions. More and more studies are now reporting on concussions. And if we think about concussions in the sport, how do you set up your race medical team? Should there be a concussion expert in these teams? And interesting thing to look into. There's obviously tendon ruptures, joint dislocations, and not just lower limb, we see upper limb dislocations, maybe from falling potentially, and then obviously frost injury when you're in a more snowy environment. Here again, I want to emphasize this is rare fatal injuries. Yes, I don't want to chase people away from the sport. It is a fantastic sport that can play a big role in public health. So we don't want to chase people away. We just need to look into the consequences of this. So here, for some of these fatal injuries were just plain blunt trauma. We're falling off a cliff, for example. But some of these were falling on a trail. You get blunt trauma wherever on your body, and you can't move anymore, meaning you can't walk yourself out of there, you can't run. And then while waiting for medical support, these guys unfortunately passed away from hypothermia. So this is really things we need to consider, and access to these runners, and how quickly can you get there, and how should we potentially set up our aid stations. There's obviously reports on animal attacks as well. Again, that is something a race organizer has to consider. That's difficult to control, but you have to consider that as well. Rare, I want to emphasize this. If you look a bit more into the risk factors in this, I'm going to tap into this living systematic review. At this stage, we have 14 studies reporting on risk factors. And again, only 3 of these studies followed participants prospectively, where we can account a bit more for the temporality of risk. Further, it's all cross-sectional studies. I want to further highlight the limitations of this. Most of these studies use univariate analyses. I said there's short-term follow-ups. These results are not replicated in multiple studies. They focus mainly on males. So what unique profile can females potentially bring to the sport? And it's not reported in race distance categories. So do we just assume that the longer distances have the same risk as the shorter distances? That is all things we need to consider at this stage going forward. Now, these updated findings we do publish on our website. And I'm not going to go too much into these risk factors because of the limitations of this. These risk factors is not really guiding us in clinical practice at this stage because it's very weak evidence that we have on it. There's about 40 risk factors at this stage, and they fall in the domains of training variables. There's some surface exposures that now show that certain surfaces is at higher risk. Some psychological factors and personality traits of these runners looks like it puts them at higher risk. Their running experience, their type of occupation, and then there's some studies reporting specifically on sunburn risk and muscle cramping. As I said, I'm not going into too much detail in this because at this stage it's not going to help us too much considering the low quality of evidence. Now, the problem is now, do we sit back? I highlighted now that we don't have good scientific evidence to support us going forward. So do we just sit back and say, let's build evidence over the years, and then later we'll try and manage the risk? And obviously the answer is no. Considering our limited scientific evidence we have, we said, let's maybe tap into the clinical experience component. If we have very little research evidence to guide us, then surely there's some clinicians out there that work often with these guys, and can their clinical guidance, while we're waiting for the research evidence, maybe provide some light in the field to continue helping. So what do we have? What has been done so far? So Martin Hoffman and his team, they've put out very good clinical guidelines for pre-race medical planning. Malta was a fantastic study to read. I just want to highlight it here that they gave some guidelines on how to organize your resources, where to place medical professionals, what should be in your medical kit. They highlight the importance of pre-race runner education and pre-race runner clearance. But the details here we don't know. We don't know what to educate them on, and how do you make the call on stopping a runner from participating? How do you clear a runner? What exactly should be in your kit? And all of this should be guided by the injury profiles that these guys have. And at this stage, we really don't know. So we designed an application, and before I discuss this, I want to make it very clear, I'm not marketing an app application here. This app will first have to go through a feasibility trial to see if it's in any way useful or not. But I just want to show you some approaches out there at this stage. We designed the application that can be used as a clinical decision aid, just to make a bit better decisions surrounding risk management strategies in the sport. So we identified risk factors in multiple studies, in literature searches. We talked to trail runners to get their perception on what is risk in trail, and we gave that to a panel of experts, and they decided which are relevant in the context of trail running. We then designed into the application, we gave it Likert scale points, where for each risk factor, this is just showing one risk factor, but for each risk factor, we gave Likert scale point values to say that 0 is low risk, 4 is a high risk, and there's some content on you can pick what's relevant to your runner. We, for each risk factor, then also went and gave it weightings to say that, if I just highlighted there, that on the left, 1 to 26, there's risk factors, and it shows you which risk factor you should probably prioritize in context of your runner. Again, we don't want to take a reductionist approach and just say that one risk factor has an approach to injury. This is why we give this advice to the clinician, not to the runner. We give it to the clinician to make the decision in the context of your runner. For example, there we're busy with an assessment of a trail runner. The application gives us some advice on where to focus. So there's training variables, running equipment. If I go down to some of the behavioral factors, psychological factors you have to consider, and all into biomechanical factors going forward. So this gives some advice to the clinician. We're not taking the clinician out of the context. We want the clinician to use this information, give context in the trail runner's position, and advise him or design a risk management strategy that can work for him. Okay, because the same 21-kilometer athlete will have a different approach when he runs in the mountains compared to running on a sandy surface going forward. This is how the application looks like. Again, I want to emphasize, we are far from putting out this for the public. This is just something that might in future help. So you're busy there assessing your runner, you tick whatever is appropriate. You go through all the questions. I'm just showing an example here. There you click whatever you feel works, and it gives you a results page to show where should you maybe focus your management strategy at, and where is your higher priority of risk. And that you can save in future. If you do an assessment, you can compare how it progressed. Last thing, if we now talk a bit clinical, so I'm using your example. This runner had a medial knee instability episode, injured the MCL, so he's a bit in the rehabilitation at this stage. So we do take on normal approach as we would take for normal road running. Some functional exercises. We do isolate certain structures in our strengthening approach. We obviously do our normal plyometric trainings in straight lines, but in the sport, in clinical practice, we do take a similar approach almost as we take for football players, where there's a lot of multi-directional work that we do. We obviously, our balance and proprioception will focus multi-directional. Our plyometric training will bring in a lot of sagittal plane work as well, and we do a lot of single leg and single leg power type of stuff in the sport. This typically, I won't spend too much time on for example, a road marathon runner, but in trail, we see this as very important considering the joint instability episodes out there. But obviously there's a lot to discuss here, and we can maybe afterwards in the questions go a bit deeper into this.